it's not necessary to wear compression for a long time after endovenous treatment.
Let's start with the discussions on PVI book trials and the trials you two are involved about those vein disorders and reflux and the way we can treat it really well or better.
So in the PVI trials book, we went through all the interesting articles and big RCTs, if they were available already. I think about 10 years now, data from 10 years, and we took out the main articles or the most important ones. A few of them, when we talk about superficial venous disease, there are a few of them who investigated the compression that's needed after the endovenous treatment. So that's still something which is debatable. We also had a discussion on this topic at one of the PVI meetings on compression after endovenous treatment, yes or no. And indeed, the papers are concluding that they cannot draw big conclusions, but they can say that it's not necessary to wear compression for a long time after endovenous treatment, and that if you want to do it, you should do it the first week after endovenous laser treatment, for instance. But it's not necessary to do it longer than 1 week. So the first few days even are the most important ones.
But one question that I have is this a chronic disease? So it means it's forever. So the benefits of the elastic compression, so the trials shows that there is no benefits if you do the compression like forever. The benefits are in the first week only. In what kind of compression do the trial suggest? Is 30 to 40 or is 20 to 30?
Yeah, that depends on the study. So some of them are talking about low compression, class 1, and other ones are talking about 20 to 30 millimeters mercury. But I think you're right. This is a very important point because you need to have an idea on what disease are we talking about. Is it really a severe stage of chronic venous disease or even chronic venous insufficiency, or is this just a problem of C2 disease where you only have visible veins and some symptoms, but you don't have the complications yet, or the venous hypertension issues in the skin, or the swelling of the limb. And I think that's the main issue, that if you're only looking at compression as part of your intervention, then I think these studies are correct, saying that the benefit of wearing it to make your treatment more efficient. I think in these studies, there is not much evidence suggesting that your laser treatment will be better if you wear compression. And that it's mainly the focus on the quality of life of your patients and the remaining symptoms that they have afterwards.
Okay. And teaching this point of quality of life. So like patients, they have like active ulcers. So it's a good point for them because you have to wear the stock compression for only 1 week. So they so can get benefited on this treatment too. All right.
Yes, indeed. If you have a venous ulcer, you should continue your compression even after your endovenous laser treatment or your venous hypertension is resolved, because we know from other studies, and that's also in the PVI book. There are some studies about compression in venous leg ulcers, especially in preventing recurrences. We know that wearing compression in recurrent is important to prevent the ulcers from recurring. Yeah.
Yeah, well, my focus for the trials book is on pelvic venous disorders, and I think it's very nice that both in the book and also at the conference in December we will discuss pelvic venous disorder. I think we all know from clinical practice it's a big problem. Lots of patients and especially women suffer from chronic pelvic pain, and we now know that pelvic venous problems are a big part of it. And the difficulty is we're talking about, well, actually a very wide clinical presentation. Patients do not all have the same complaints. And we are also talking about a variety of underlying problems. Because I think in the past we were speaking about pelvic congestion and we said, well, it's a reflux of the ovarian vein or the internal iliac veins and we have to coil it. And then we were discussing compression syndromes, which you can stent common iliac vein or maybe even renal vein. But I think we now are all more kind of getting convinced that it's all one big network of underlying problems leading to pelvic venous disease. So we have to find out whether there's reflux, whether there's obstruction, whether there's maybe both. And then there's still the challenge how to find out which patient is the patient that actually has complaints caused by a venous problem. What is the venous problem? And then find out what is the best treatment. And well, I think we're gaining evidence. There's not a lot of big RCTs, not a lot of big studies, but we are doing more and more studies in the world. And I think there's a very nice studies coming now. The next trials book, we will present one study, and it's actually about, well, it puts focus on how you should make it not a standardized protocol, but actually individualized protocol for each patient to find out what is exactly causing the problem and how to treat it. And for instance, we have a trial on also long-term follow-up that in patients with both reflux of ovarian vein and compression of the common iliac vein, often when you treat the compression, when you stent the common iliac vein and resolve the compression, that's actually the cause often of the reflux of the pelvic complaints. And if you solve that problem, then the patient complaints are gone. So you don't need to treat everything you see, but try to find out what the real cause of the problem is. And I think that's very interesting to focus on and to put further research on. And that's the good thing of PVI. I think that we will also be there in December and we'll actively discuss about it.
Yeah, I agree with you. And there's probably a higher variety of patients, of symptoms, anatomic points of the start the disease. So it's hard to put all of them in the same basket and treat it
Yes.
equal. So I
Yes.
think that's the hardest point. So first
Yes,
of all,
absolutely.
yeah, we need to talk about symptoms. So the first point, yes, symptomatic treatment, not just imaging diagnostics. Yes,
Yes, absolutely.
and yeah, and then second, uh, renal vein and pelvic veins are like connected. We need to know where start the disease, right? Am I
Yes,
right?
absolutely. Yes, you're right.
Yeah,
Yes.
and well, especially on embolization. So we need to see what kind of symptoms. If we have renal symptoms, or we have only just pelvic congestion. So the treatment is totally different, right?
Yes, I
So
agree. Yes.
yeah, like hematuria and back pain, and so I just treat hematuria and back pain. So I look for renal vein. If I don't have these symptoms, I go direct to pelvic congestion. I don't know if you agree with that.
Yes, well, I think the problem is that the typical clinical symptoms are often a bit hidden. So some patients really do present what we think is the typical, well, like what we used to call pelvic congestion problems or the typical compression of the renal vein complaints. But often that's not the case. Often it's a variety of symptoms that could fit either compression of the left renal vein, it could fit with ovarian vein reflux. So it's difficult. So you really have to listen to the patient, really think about alternative diagnosis, and also combine the clinical picture with the imaging we have, and then try to make sure you choose what best for the patient, which is, well, definitely a challenge, and we're not there yet. I think we all want the big book telling us where to go, but the standardized treatment for these patients, well, it doesn't exist.
Oh, yeah, absolutely. So, and if you have like both symptoms, like iliac veins due to iliac veins or renal vein, I know you have to see the patient's symptoms, ask request for imaging diagnosis, but probably what you just said that if we treat the iliac vein first, there's a high percentage to solve the problems, to solve the symptoms instead of treating the iliac vein first. Yes.
Yes, well, we do have some evidence. There's two papers on when there's compression of the common iliac vein and also reflux of the ovarian veins or the internal iliac veins. And when you do stent the common iliac vein first, in most patients the complaints resolve. So that would be there the first treatment. But on the other hand, when a patient suffers from complaints of left flank pain and has hematuria, and you see a compression of the left renal vein, and also maybe due to how the patient is built, also a common iliac vein compression, then common iliac vein compression might not be the first step. So there is a lot of, well, debate and a lot of clinical reasoning behind it, and to try to make the right choice.
Okay, but in the worst case, if this patient has both uh, renal and iliac vein compression,
Mhm.
we should not treat both at the same time. Yeah, you treat one and then you take a while and treat the second, or not.
Yes, I would agree on that. There's not a lot of evidence for that. So I think, well, we cannot here in this question, we cannot rely on the trials book, but we do discuss this issue at the conference in December, because I think, well, I think if you're not sure what you are treating, and if you're still in doubt treating two things, then you still don't know what's actually the best treatment. So I would always go for one of both, but I think, well, we can definitely have a debate on that.
Okay, I have two more questions, then I come back to Sarah again. Uh, should we um, investigate about women's, mainly women's symptoms about sexual dysfunction, or we should still ask about that or not? Is it
Yes,
a
I think we should.
dyspareunia is probably the main question or not?
Well, the main, I'm not sure, but it's definitely one of the big issues and one of the big questions. Definitely, yes. Yes.
Okay. And the last one probably about the treatment. I'm from Brazil. So in Brazil, unfortunately, we're not allowed to treat pelvic vein reflux. So the insurance companies don't let us to do it. So like doing coiling. So
Mm-hmm.
they don't let us do it. As an alternative, what do you think about foam polydol canal so we can get a recurrence of the disease in a couple of years or several years? What about glue? My point of view, glue, I know that Europe, you do a lot of glue for embolization, um, but my question is about the technique procedure, like how we can see, because there is no contrast, or you put some contrast, what is it difficult to treat with glue?
Mm-hmm. Well, it's a good question. I don't have any experience in the technique of treating with glue, but I think it might be an alternative, and I think you might be able to add some contrast to it, so then you can, well, at least do imaging and see the glue, pushing out contrast for incompetent veins. So it definitely might be an alternative, but I think the best alternative would be that we actually should gather more evidence, should do more research, and then convince also insurance companies in Brazil that it, some treatments really, really improve patient complaints and improve quality of life. And well, they should consider allowing treatment. But of
Okay.
course, we need more evidence than we have now. I can imagine that.
Oh yeah. You do coil or you do plug?
We do coiling. I think plug is there is one paper also in the book with similar results. So I think both is fine. Our technique here in my hospital is do coiling and also sclerotherapy. So
Yes.
both. Yeah. So do coiling and then with a microcatheter pass the coil and then do foam in the small branches deep in the pelvis.
And it's not necessarily like 10 coils on each side. Yes. Maybe you
No,
do
no.
like 1, 2 is enough. Yes.
Yes.
Okay. That's
I
perfect.
agree. Yes.
Okay. Thank you. Can I come back to Sarah again?
Yes.
Okay, Sarah, I want to ask you one more thing about after endovenous treatment and elastic compression. And what about medical treatment? Again, we're treating chronic forever disease. And do you do medicines like clinical treatment plus stock compression or not?
You mean in the beginning of your treatment plan or after the endovenous treatment?
Like in the beginning, I believe you do, but
Yes.
after treatment, the patient got relief of the symptoms. But if we are treating something that's chronic, maybe 5, 10, 15 years later, the symptoms will come back. So what's the plan for clinical treatment?
Yes, I think in our case we tend to give the patient some medical treatment after the endovenous treatment for a period of 1 month to 6 weeks. And then we try to stop it and see how the patient is feeling. Again, it's a very it's symptom controlling that you're trying to do and to improve that. It's sometimes necessary to continue the medication for a longer period. And if the patient still has a lot of issues of skin problems or recurrences after your treatment, you can restart it. But we don't tend to give it longer than 6 weeks post-op. But in some ulcer patients, we believe that maybe giving it for a longer time until the ulcer is healed is also something that can be preferred. But in Belgium, there is no reimbursement for the medication. I don't know how it is in Brazil. Is it reimbursed? No. So for some patient, it is something extra, an extra cost. And then I think that compression and all the wound care products are more important than the medical therapy. Yeah? But it can be it can be like an adjunctive treatment.
Okay. And any specific type of phlebotomic or just
Yeah, in the trial book we have one study that I mentioned that I put in the ulcer. I think it's in the ulcer, and it was with the flavonoid, with the micronized purified flavonoid fraction. I think they have the most publications on also with venous leg ulcers. And in the trial book, we have a systematic review and a meta-analysis. But this is not specific in venous ulcers, but it's in chronic venous disease that it can be an adjunctive therapy on top of the rest of the compression of the more definitive treatments with your endovenous treatment options that you have.
Okay, perfect. And the last question about endovenous superficial veins treatment. The main device probably is laser, yes, but what do you think about radiofrequency and of course the one that does inside vein traumatic and form?
Yeah. Also in the book, and I think we all know that there are a lot of comparisons. I would say then compression is is key, stays a key treatment after treatment of the venous hypertension, especially to avoid recurrences of venous leg ulcers.
Okay, thank you.
Very nice. Yeah, and I would say for pelvic venous disorders, we are, I think, improving. We have much more knowledge about it. I think much more international communication and much more understanding of what process we're actually speaking about. But I think we definitely do need interactive international discussions on everything about it, diagnosis, clinical picture, imaging, and also treatment options. So it would be very nice to discuss further.
Yeah, we need to discuss much more time, much more about all these topics and to see what we can do better for our patients. No, there's not is just one answer for everybody.
Totally
So
agree.
Yeah.
yes, that's my take-home message. And I would like to invite other colleagues to contribute to the online platform and be present at the PVI Congress. So you two be there, I will be there too. So it's a nice event with all the best colleagues on the world will be they attend to the event. So is everybody get connected. It's a friendly meeting, and we asked the platform administrators to put the link and let those other colleagues to contribute online and send in their case so we get more discussions and improve our treatments and now of course our patients outcome.
Yes, indeed.
Definitely.
We have a good session again, like every year in an Agora session, where we always have very interesting venous cases that we discuss, as you mentioned, with all the experts from all over the world. And it's very nice to have a good interaction and some other opinions. So it's really helpful, and I think it's a really big call for very interesting cases. Please send them to us, so we can have a very nice session on venous disease. I think it's on Thursday, right, Jorinde?
Yes, it's on
Yeah,
Thursday.
Thursday afternoon. Yeah,
Okay, yes, the first day.
the first day. Yeah,
Yes.
it's Venus Day. Huh?
All right, that's it. And also it's an interactive event too. So as you just mentioned, even the most shy guy can get the microphone and say something because it's all the colleagues are so friendly.
Yes, and indeed this
Yes.
year also we made a program, especially on the deep parts, Jorinde, with some very nice interactive, I think, possibilities, because it can be either your con or your pro, or you will have your opinion. So I think it will turn up to have very nice discussions on the different items. Yeah.
Yes, I think so too. And
Alright.
especially in a field where we don't have a lot of strong evidence yet. We have to find ways to create it and also find out and learn from each other's opinions and experience. I think it's very important.
Yeah, everybody's opinions contribute a lot.
Absolutely.
Yeah.
Friend interview.
Well, thank you.
Thank
Hopefully,
you. And we will see you in Paris, huh?
yes, I will see you
Thanks.
to Paris, and hope these contribute to someone else that can watch it. All right,
Yes. Thank you.
Thank you.
my pleasure. Bye bye.
Bye.
See you. Bye.
Enjoy the day.
You too.
Yeah,
Bye
you
bye.
too. Bye.